Okay, let's dive straight into this explainer. We're running a rapid-fire clinical drill focused entirely on surgical wound management and perioperative infection control. These are strictly high-yield facts, so let's get right into the questions.
Section 1. Empiric Antibiotic Therapy. Question 21. Which antibiotic class is considered first line for uncomplicated cellulitis without an associated abscess? Looking at the choices, the correct answer is A. Amoxicillin.
The clinical reasoning here really hinges on the organism. Because we're dealing with non-purulent cellulitis, beta-hemolytic streptococci require narrow-spectrum beta-lactams. You'll definitely want to remember these exam pearls. Your standard outpatient choices are amoxicillin, dixloxacillin, and cephalexin. But for your penicillin allergy strategy, you need to pivot to clindamycin or macrolides.
Section 2. Surgical Wound Classification.
Question 22. An emergency appendectomy performed for a ruptured gangrenous appendix is classified as which type of surgical wound? The correct classification is C, Class 3, contaminated.
This is because it involves a ruptured viscus, but crucially without a mature abscess. Let's look at these exam pearls side by side. An uncomplicated appendectomy is Class 2. Once it's ruptured, it upgrades to Class 3. But the exact moment you encounter a mature abscess or peritonitis, you're dealing with a Class 4 wound.
Question 23. What is the expected postoperative infection rate of a Class 4 dirty wound if no prophylactic antibiotic coverage is administered? The correct and frankly alarming answer is E, 40%.
This surgical wound infection risk table maps out wound class from I to 4, showing infection rates both with and without prophylaxis. It's wild to see that massive jump to a 40% infection rate for Class 4 wounds when prophylaxis isn't given.
Question 24. A 30-year-old male with an acute gunshot wound penetrating his right buttock. How should this surgical wound be classified? The correct option is C, contaminated, Class 3.
The reason here is that it's open, fresh trauma, lacking old necrotic tissue. Keep these exam pearls in mind for the mechanics of each class. Class 1 is clean, Class 2 is clean contaminated, Class 3 is contaminated, and Class 4 is strictly dirty.
Question 25. Which of the following procedures serves as a classic example of a Class 2 clean contaminated surgical wound? The correct example is A, elective cholecystectomy. Why is that? Because a hollow viscus is entered under strictly controlled conditions without major spillage. Some high-yield exam pearls to memorize. A breast biopsy is Class 1. An elective cholecystectomy is Class 2. Diverticulitis is Class 3, and an abscess IND is Class 4.
Section 3. Prophylaxis and infection rates.
Question 26. What is the most widely utilized preferred first-line option for standard perioperative prophylaxis in clean contaminated surgeries? The preferred choice is C, first-generation cephalosporins.
The core reason being, cefazolin offers optimal coverage against skin flora. Make sure you know your exam pearls here. First-gen examples include cefazolin and cephalexin. And the absolute most critical timing pearl, administer within 60 minutes before the incision.
Question 27. What is the most appropriate prophylactic antibiotic regimen for a patient undergoing elective vascular repair? The correct regimen is D, augmentin and gentamicin.
This specialty-specific prophylaxis table perfectly maps out core targets. You can see how surgical types like vascular, orthopedic, and biliary operations are paired with their core pathogens and suggested agents.
Question 28. According to AHA and ESC guidelines, antibiotic prophylaxis for infective endocarditis is strictly indicated in which surgical candidate? The correct candidate is B, a history of mechanical aortic valve replacement.
The reason is that prophylaxis is restricted exclusively to patients facing the highest risk adverse outcomes. For your exam pearls, high-risk indications include prosthetic valves, prior infective endocarditis, and specific congenital heart diseases. Remember, prophylaxis is not indicated for routine CABG or isolated mitral valve prolapse.
Section 4. Operating room protocols and infection control. Question 29. A 45-year-old male's pre-op screening reveals he is HBV positive before a laparoscopic cholecystectomy. What's the most appropriate next step? Option A, proceed with strict universal blood-borne precautions.
The guiding principle here is that known positivity is not an indication to delay surgery.
Exam pearls for universal precautions include double gloving, utilizing face and body armor, strictly using a kidney dish or neutral zone for passing sharps, and wearing protective footwear.
Question 30. What is the most effective administrative measure to decrease nosocomial surgical site infections within an active operating theater? The absolute most effective measure is B, strictly minimizing movement and number of staff.
It all comes down to the physics of the room. Movement causes a disturbance of the established sterile laminar airflow ventilation. Key exam pearls are your laminar flow systems, the 1-meter distance rule, and proven risk reducers like normothermia and supplemental oxygen. So it really leaves you wondering how many surgical site infections could be entirely prevented just by keeping those OR doors shut and traffic to an absolute minimum.